syndrome, also known as TSS. The first thing we'll be discussing is the transmission of the disease, which can be transmitted in many ways depending on the form of bacteria. Staphylococcus aureus and Clostridium sordelli are normally found on the body, but it's not infectious until it enters the body in some shape or form. Staphylococcus aureus are usually found on any part of your body. It usually infects you when it enters an open wound, whether it be a cut from a surgery, when it gets infected, or just any cut in general by penetrating into our bloodstream. Clostridium sordelli is normally found in women's vaginal area, but it's not infectious until it enters the uterus through menstruation cycles, childbirth, or gynecological procedures. And on the other hand, Streptococcus pyogenes is a secondary infection, meaning that it occurs during or after the treatment of another infection. Such infections include people who have had chickenpox, bacterial cellulitis, or people who are immunocompromised. Reinfection is a high possibility. So for those who have had TSS in the past, it's important to avoid the use of tampons and to be cautious of using diaphragms as a contraceptive method. And in case you have a wound, make sure to practice proper wound care. Next, we'll talk about the symptoms and the diagnosis. So the list of symptoms goes on. There's quite a few, but to name them off, there's the fever, a rash, vomiting, diarrhea, hypotension, which is also known as low blood pressure, conjunctival injection, which is also known as bloodshot eyes, which are enlarged vessels in the eyes, strawberry tongue, which is a red, bumpy tongue with enlarged taste buds, desquamation, which is skin peeling, and myalgia, known as muscle pain and muscle ache. The diagnosis will be handed off to one of my teammates.
The diagnosis for TSS is one or two ways. You can either take a blood urine test or a swab. In the blood or urine test, doctors will see if any staphylococcus or group A strep is present, and in the swab they will swab the vagina, cervix, or throat for samples. Keep in mind, TSS isn't just like something you can, like, there's a specific test for it. No, it's just something very common, like to see if there's anything in the bloodstream. It's mostly in the bloodstream, so keep that in mind. That's why there's no like specific diagnosis of how like to diagnose something like this. It's just kind of looking to like the symptoms and all that stuff. So,
and moving on to the treatment and prevention of TSS, it's treated if you have TSS, you should immediately be hospitalized. Any tampons or contraceptive devices should immediately be removed from the patient, and patients will often be given intravenous fluids and medication to help with the infection and or manage blood pressure levels. Staph infection will typically be treated with intravenous administration of antibiotics to help the control of growth of the bacteria. However, this doesn't fully eliminate the toxins accumulated within the body. Some severe cases will even be treated with infusions of intravenous immunoglobulins, which are any case of proteins present in serum or cells of the immune system. As for the prevention, you should definitely follow directions when it comes to using vaginal contraceptives, such as sponge and or diaphragms. For surgical incisions, make sure to keep them clean to avoid infection. Avoid the use of tampons if you're not on your period, because that's definitely, they're not meant for anything else. And during menstruation, make sure you are using the tampon at the lowest absorbency. Make sure to change them out frequently. Don't keep them in longer than it tells you to, because that's definitely a high risk for infection. And many people who have had cases of TSS before should avoid the use of tampons specifically women, obviously.
At risks and characteristics for this disease are at risks are tampon users and recent procedures. For tampon users, if they use highly absorbent tampons, they have a higher likelihood of contracting the disease, generally between ages of 15 to 25. For example, if you use really high, super absorbent tampons and they do not match your flow is lighter than that, then it will cause this disease to come up. And then another thing are recent procedures such as surgery, surgical procedures. There runs a higher risk in developing TSS after gynecological procedures, wound infections from surgery, induce spontaneous abortions, and the use of birth control devices, such as diaphragm and contraceptive sponges. This is because through said procedures, there runs a risk that bacteria enters our cervix or bloodstream. So this means like after any surgical procedure done from anything, it can be anything, but in women specifically, if you have a abortion and there are higher risks for you to grow if you don't take care of everything and keep it clean, you run a higher risks of grabbing an infection and there are some bacteria that grow very well with those types of infections. For example, the characteristics of TSS are bacteria such as Staphylococcus aureus, and these are gram-positive facultative anaerobes, and they grow in temperatures between 15 to 45 degrees Celsius, and S. pyogenes, which are gram-positive aerotolerant. Optimal growth temperatures is 37 degrees Celsius. And the C. sardellii are also gram-positive anaerobes, grows between the temperatures of 25 to 40 degrees Celsius. And what these all bacteria have in common is that they can all grow in body temperatures. So, body temperature for regularly is 37 degrees Celsius. As you can see, all these numbers and temperatures correlate to our body temperature. So they can grow in our temperatures. And the mechanism of pathogenicity is that all these bacteria, the exotoxins of all these bacteria, can acute on set illnesses.
Now that we know a bit more regarding toxic shock syndrome, we will be talking about a real-life case report that was published onto the Oxford Medical Case Reports. To start off the case report, we can briefly go over what we know about the patient. For starters, she is a female 16-year-old that is a competitive swimmer and has a history of asthma. She is also not sexually active and had her last menstrual period 3 weeks prior to being admitted to the emergency department. Since then, she has denied the use of tampons. Her first visit to the emergency department was at 7 in the morning, and she experienced the following symptoms. Her primary complaint was abdominal pain that was localized to the right upper quadrant and described as aching in nature without radiation. She also complained of body aches and nausea. In addition to the previously mentioned symptoms, she had a headache, shortness of breath that lasted roughly 3 days, and stated she felt a lump within her right breast. With this information, a few tests were done. First of all, an abdominal exam was done and revealed that there was minimal tenderness in the right upper quadrant, but no peritoneal signs. Next, they examined her right breast and revealed that there was no fluctuant erythema or obvious lump. However, it was mildly tender inferior to the right areola. To continue with the physical exam, they did a chest radiography, abdominal ultrasound, and a laboratory evaluation, but they all came back unremarkable and with no problems. To treat her existing tachycardia, also known as abnormally rapid heartbeat, she was given intravenous hydration and began to improve. She was also given ketorolac, an anti-inflammatory drug to help with her muscle aches. Due to the unremarkable tests and help of intravenous fluids, the patient was discharged and was recommended to follow up with her OBGYN and return to the emergency department if her symptoms worsened. After a visit with her OBGYN, she presented with new symptoms and visited the emergency department for a second time at 3 in the afternoon. She presented with a diffuse rash and fever. She appeared flushed and had a temperature of 101.4 degrees Fahrenheit. She also experienced full-body erythema, which is also known as a superficial reddening of the skin, usually in patches, that is a result of injury or irritation and causes the blood capillaries to dilate. As can be seen in the 3 photos, she experienced this primarily on her back, legs, face, neck, and chest. Lastly, there was a clear worsening of the lump on her breast. Examination of the right breast revealed no external evidence for infectious process. However, there was a deep 2.5 centimeter tender nodule located inferior and lateral to the areolar border of the right breast. With these new symptoms came new tests. For starters, they did an ultrasound on the right breast and several cystic areas were revealed. The patient was then given vancomycin and clindamycin intravenously, which are both antibiotics. Vancomycin is used against resistant strains of Streptococcus and Staphylococcus, whereas clindamycin is used for the treatment of a number of bacterial infections. However, despite fluid resuscitation, the patient's erythroderma continued to worsen and blood pressure continued to rapidly decline. Because of this, she was started on norepinephrine, a hormone used to treat low blood pressure and heart failure. Later, a pelvic exam was done and came back negative for acute process or foreign body. The patient was then taken to the operating room and the right breast abscess was drained. After the drainage of the breast abscess, a culture was done and the culture of the wound showed the presence of Staphylococcus aureus. However, after the drainage, the patient improved and was off of norepinephrine. The patient continued to rapidly improve and was discharged with an oral prescription of clindamycin with a planned antibiotic duration of 10 days. At her 1-month general surgery follow-up, the patient continues to do well and has returned to competitive swimming.